Hey everyone, it's Dr. Chris Shaver, host of the GI Show, and we are here with you for the GI Show. And we're talking about irritable bowel syndrome, which is a really important topic that you need to know about. In fact, I've titled this Understanding Irritable Bowel Syndrome for the first time because number one, I kind of want to demystify it for you guys and just sort of help you understand it on a kind of a core level. And also I don't want to really assume what you do know about it. And so I want to dispel any myths or misunderstandings that may be taking you down the wrong path in understanding and dealing with maybe your diagnosis of irritable bowel syndrome. So anyway, welcome. We are filming here at the lovely BGA Studios. So I'm very excited to present to you my special guest, Dr. David Landy. So let's transition here at the GI Show with Dr. David Landy, my special guest, talking all things irritable bowel syndrome. And by the way, let me go ahead and mention this, is please check out our website. We at bgapc.com, it is a valuable tool for you guys. You can reference physicians, you can look at our blog, which has a lot of information about IBS and all the other things GI. We post previous episodes of the GI Show. So bgapc.com would be a good resource for you guys. So check that out. So pain, abdominal pain, is again a hallmark presenting feature of IBS, and it can be a problem. We talked a lot about diarrhea, constipation, alternating, but pain is there, and it is it's a real issue for these patients. Should we use narcotics?
No.
You said that before I finished the question. You said no. And I could not, so preach it, brother. So narcotics are not an option in IBS patients, not even one pill. And I feel strongly about that because they can be very addictive. They can be habit forming. They really cover up the symptoms. And so
it doesn't work.
And that's what I'm kind of getting to is long term they actually can make pain worse. And so hard truth for patients to hear because they're in pain and they want immediate relief, and that's where the education part comes in and the reassurance and developing that rapport where our patients trust us to kind of help guide them through those decisions and do what's best for them and by them. And that would involve absolutely not prescribing opiates for this condition. And so keep that in mind. But there are some options though. As we talk about this art of IBS management, pain can be maybe approached a little differently. One thing I do, and I'll just go ahead and say it, is I do use antidepressants for IBS, and in particular, and it's really all about getting back to brain and gut and modulating pain at the central level, and that's where I think low doses of what we call tricyclic antidepressants, brand names are Elavil and Pamelor and others, and we use those really, one, they decrease pain, and the data is not very, very robust, but we know anecdotally that in our patients that we see relief from pain. And they also help you sleep at night. I dose them at bedtime so they can treat any underlying associated insomnia. And they also have an anticholinergic effect on the gut, so they slow things down. They act like a brake, and so they actually can help decrease diarrhea. So to me, they're really a good option in patients who fail a first-line treatment like over-the-counter with diarrhea. This can help, and they have a lot of pain. Then a low-dose tricyclic can be a game changer in those patients, not in everybody. And that's the frustrating thing about some of these treatment options that we're throwing at you kind of rapid fire, is that they usually don't work. So we need a lot of them. We need a lot of choices.
Yeah.
That's just the data. They usually don't work, but they do work in a certain percentage of people. and there's a very high placebo effect in a lot of these studies. What we see in a lot of IBS patients, the placebo effect in randomized trials is really high. So the therapeutic gain when you compare a drug that has that's shown to be statistically effective is sort of minimal because you have this high placebo effect. And so that's where you have to, a little bit, when I treat my IBS patients, I really have to manage expectations a little bit. We're gonna see you. You're gonna come in. We're gonna examine you. We're gonna take care of you. We're gonna educate you. This video is part of that education process, but we're gonna treat you, and it might be over the counter. It might be dietary,
Right.
A low FODMAP diet, for example.
Yeah.
Avoiding triggers in the diet, things like that. We're going to treat you, but it's a trial and error process, isn't it?
Right.
It really is.
I was going to say there are two dietary things that I usually talk to patients about. I mean, I think a low FODMAP diet is pretty good, and I wish I'd think of that more often because I think it works pretty well if people can adhere to it. And diet is very hard because it's hard to adhere to diet. And I usually don't mess with the gluten-free because it's very difficult to do that.
Right.
But the low FODMAP diet can be very helpful. And the other thing I always talk to patients about is lactose, because lactose is found everywhere, dairy products, and lactose intolerance is very, very common. And I'll usually have a conversation with patients about lactose because sometimes that can be adding to this or even causing it.
Right.
And I don't do fancy tests for lactose intolerance. I tell people and this is part of my IBS thing, is I tell them just avoid it for a few days, then challenge yourself with a glass of milk, and usually you'll get an answer with that. And I've had some people say, hey, I know I'm lactose intolerant based on that, or and then if they're not, then you can say, well, don't worry about it.
Yeah.
So.
Gotcha. That's good. That's good. I do use diet modification and in my practice with pretty good success. Alrighty. So last but not least, so the paradigm has shifted a little bit in the last month for us, hasn't it? When we practice, and with COVID-19, with enforced quarantines, a lot of our IBS patients are sequestered at home, and they still have IBS. They may have limited access to primary care. Telehealth has really emerged, I think, as a way to reach out and treat these patients. Have you used telehealth the last few weeks? I know we've launched it in our practice. We use it.
Right.
How has that worked for you in talking to IBS patients? What's that experience been like?
Honestly, so far it's only been a month.
Yeah.
And I think telehealth it might be here to stay. And I think for me, one of the things that I think is really advantageous to telehealth is that you can access so many more patients can access you, and you can access them more. In our practice, we do satellite clinics, and we do a lot of work in other places, and sometimes the patients can't get to us because it's too far away and we're not always out there, and so they can telehealth in, and
Right.
we can talk to them and help them over the phone. Most of the telehealth I'm doing are people that are having maybe a higher level of issues than IBS so far, but I think we can certainly help people with IBS with telehealth. I think it's a good way to do it as well.
Gotcha. Good. Well, I think that about wraps up, and I think we could go on and on with this. It's been great, and I appreciate Dr. Landy. I appreciate you and your really practical sort of approach to this and common sense approach to IBS, and that's been really good. And so, any closing comments?
Well, I just want to say I appreciate you doing this because I think that that this is a service for our patients and population, and I think it's not something that is expected of you. So I think it's really nice that you're doing all this.
I just wore a really boring shirt today, so sorry about that. I'll work on that. Thank you guys as always, and we wish you good health as you navigate these sort of tough waters in this COVID-19 pandemic. So be safe, be careful out there, and from the shadow of Vulcan, right back this way, stay regular.